All right. Good afternoon, everybody. Welcome. Thank you so much for joining us today. My name is Amy Killelea. I'm an assistant research professor at Georgetown Center on Health Insurance Reforms, and I want to welcome you all to our latest webinar in a series of webinars from CHIR on advancing diabetes coverage and access in the private health insurance market. For those of you who are new to the Center on Health Insurance Reforms, we are a nationally recognized team of health insurance experts within Georgetown University's McCourt School of Public Policy. We conduct legal and policy research and analysis. We publish reports and provide technical assistance to stakeholders and policymakers across the country, both at the state and federal levels. We have teamed up with the Leona M. and Harry B. Helmsley Charitable Trust to apply our passion for private insurance to better understand the issues facing patients with diabetes who require insulin and the reforms that could improve coverage for them. As part of that effort, we're focusing today's webinar on anticipated changes to the coverage landscape, what these changes mean for people with insulin requiring diabetes, and how providers and diabetes patient advocates can work to ensure that individuals have uninterrupted access to life-saving care and treatment. So before we get into our webinar, I'm going to cover just a few quick housekeeping matters. So first off, we are recording our webinar today, and we'll share the link with everyone who registered. If you like what you hear today, please share the recording with others in your network and get the word out. Second, the chat is open to say hi to us. And if you have any technical issue, please flag that down for us and we'll take care of it. Otherwise, we'll be posting links to a few resources as we go, so keep an eye on the chat. And then third, as we always do, if any of you have joined us for these webinars before, we have built in plenty of time to take your questions. We know this is a fast-moving and complex set of issues. We want to hear from you. You can use the Q&A function. It's at the bottom of your Zoom screen there. So click that Q&A button and you can type in your questions there. You can add questions as you go. We're going to get to as many as we can when following our panel discussion. So those are logistics, and I want to introduce our speakers today. We're super pleased to be joined by two experts in the field. They are known likely to many of you. First up, we have Laura Friedman, who serves as Vice President of Regulatory Affairs at the American Diabetes Association, where she leads initiatives aimed at expanding access to individuals with diabetes through payment-related policy changes and other regulatory actions. She also leads the public policy and public comment development process for the ADA's submission to federal agencies. So we're very, very lucky to have Laura with us today. And we are also joined by Dr. Henry Rodriguez. He is the clinical director at the University of South Florida Diabetes Center and professor of pediatrics. Dr. Rodriguez also serves as the chair of the American Diabetes Association's National Advocacy Committee. So welcome to you both. Thanks for being here today. We're going to get to your remarks in just a little bit. So what we're going to start with is just a very quick item, but the opening act to what I think will be a really interesting and dive deep conversation with our two speakers. But what I'm going to do is kick things off with a short presentation to review the latest federal policy shifts from Congress and the administration that will impact, and we're going to focus our impact on sort of two specific areas, Medicaid and Marketplace coverage. And these changes and impacts are starting very, very soon, some of them going into effect immediately. Others we're looking forward to 2026. And then following my presentation, I'll be asking Laura and Dr. Rodriguez to help us unpack what these changes mean, particularly for low-income people with insulin-requiring diabetes. So after that point, we'll start the Q&A. So get ready for that, prepare, and you can start putting your questions in there as soon as you are ready. So I'm gonna talk about the sort of three categories of different federal policies that you see in front of you, and these include both congressional and administrative actions that impact healthcare. There's many of them. These are the three that we're really going to try to focus our time and attention on because they have significant implications for people with insulin requiring diabetes. First are the changes to coverage made in the federal reconciliation law that was passed by Congress and signed into law in July. The second are changes to marketplace coverage that were included in the Marketplace Final Integrity Rule, finalized last spring. And finally, the last bucket are a set of emerging policies that have really embraced a deregulatory approach to health insurance and what that means. So next slide. So we're going to go through a series of charts here, and these are going to include the major, not all of them, but the major provisions, sort of one by one. We'll make these slides available to folks post-webinar, so I'm not going to dramatically read each one, and I know there's a lot of text on these slides. What I want to do, though, is one, make sure everybody has all of the information, but two, really try to pull out the common themes and the major dates that we should be thinking of in terms of implementation. So first up here, we have the Medicaid provisions. These were included in the Federal Reconciliation Act that was passed in July. And in many ways, these were some of the most hotly debated and will have significant impact on Medicaid coverage in every single state. You see sort of some themes from the provisions here. So first is increased documentation and paperwork to keep coverage. We'll see that as a common theme across Medicaid and Marketplace changes. So the enrollees will have to do more to keep their coverage to ensure that they are and prove that they are still eligible. Work requirements is probably one of the most controversial and significant changes to Medicaid that was part of the law. That's going to condition Medicaid eligibility on engagement in 80 hours per month of work or work adjacent related activities. If those activities are not met, Medicaid could be terminated. That one doesn't go into effect until January 2027, so it's some time for that. But certainly states are already in the implementation process, including thinking through which groups of beneficiaries will be exempt. And some of those beneficiaries could include people with chronic and complex conditions. Next, we see significant cuts to the federal funding share of Medicaid. And that's an important one. That's not necessarily as specific as the work requirements or documentation increases, but that really could put state Medicaid programs, and sort of state budgetary processes in general in a really tough spot in finding money to fill that gap from the loss of federal funding. And if they cannot fill that gap with other state funding, cutting services, cutting provider rates, really doing things that are going to shrink the program and potentially shrink access. On top of these, and again, this is a through line across Medicaid and Marketplace and frankly other areas of federal policy right now, you also see specific cuts to immigrant access. Again, a little bit of time, or I'm sorry, that one is the immigrant restrictions really go into effect fairly quickly for Medicaid, a little bit more time on Marketplace, but those are something to consider too. So next slide. The reconciliation law also included provisions aimed at marketplace coverage. So the coverage that folks can get through healthcare.gov, through state-based marketplaces. And the provisions are sort of specifically focused for people who are receiving federal subsidies. So premium tax credits, cost sharing reductions that help them afford their marketplace coverage. These provisions that you see up here, these were included in the federal reconciliation law. They dovetail with the marketplace integrity rule and some of the provisions I'll talk about that were included in that final rule in a second. And how they work together is that the provisions in the rule, as we'll talk about, were meant to go to effect on a fairly fast timeline. The provisions in the law in many ways sort of carry through, build upon, expand upon the provisions in the rule. So you've got some common themes here as well. And again, with a slightly elongated implementation time for some of the provisions. So first and foremost, and this is one where it is not an elongated implementation time, this is something that you're likely hearing about right now, and that's that the enhanced premium tax credits were not extended. So this is a bit of an absence of a provision in the federal law, and not necessarily a provision itself, but it's a really important omission because without these enhanced premium tax credits, which have made marketplace coverage more affordable for many enrollees since they've been in effect since 2021, marketplace premiums are expected to go up by double digits in states. So, these enhanced premium tax credits has really done a good job of keeping marketplace premiums low for a lot of people. Those were not extended, and if they're not extended by Congress, they expire. So as of right now, as of the filming of or taping of this webinar on September 18th, those enhanced premium tax credits will expire. Congress has not acted, but there's still time. Congress could still act to extend those through another mechanism. Though I will say time is running out. as open enrollment approaches. And for those of you who work with assisters and folks who are talking to people about enrollment options and helping them to enroll, this is a confusing situation, and especially the volatility. So that's something that we are watching and that we don't quite know how that story ends. The other provisions, are sort of along the same line of really limiting marketplace subsidy eligibility, particularly for immigrant groups. And you can see that the sort of first tranche of that immigrant eligibility restriction starts with DACA recipients, which has already gone into effect. But sort of in addition to that, adding documentation requirements to prove eligibility for premium tax credits, to prove eligibility for and to prove income eligibility in particular. So that's important. And as I said, this federal reconciliation law, those provisions work hand in hand with the marketplace integrity rule provisions, which I'll go into next. Finally, last but not least, the third of our sort of trifecta of provisions in this sort of first piece of federal updates, the marketplace integrity rule. So this kicked off some of the provisions we just talked about that made it into the federal reconciliation law. And again, some common themes here. You see the income verification and documentation requirements. Here, it's not just for subsidy eligibility, it's also for special enrollment periods. So making it a little bit more difficult to prove, to have the documentation that says I am eligible for a life change circumstance that makes me eligible to enroll after open enrollment. Limitations to immigrant group, and I misspoke. The federal reconciliation law includes the same sort of immigrant group limitations as Medicaid, and then the DACA limitation that went into effect already was included in the marketplace integrity rule, allowing plans to offer products with just lower generosity. So we're going to see plans with higher deductibles, higher cost sharing, and then finally, not this year, but next year, a much shorter open enrollment period. So all of this together, if you're thinking from a sort of consumer perspective, this is a sort of confusing array of changes to how people have typically interacted with the marketplace, and a sort of uptick in the documentation burden for enrollees to enroll in coverage, to keep their coverage. One wrinkle here, and we can go to the next slide to sort of cover the full gamut of these provisions. One wrinkle here you see a lot in red, right? That says on hold pending litigation. There is litigation challenging this marketplace integrity rule. A district court judge has stayed all of the provisions that I noted in red, so not all of the provisions, but a good deal of them. It is unclear whether and when those provisions will go into effect, but right now they are stayed as the litigation plays out. And I say this, we could, do a whole webinar on the legal and litigation side of some of these areas, but this is another element of volatility that can introduce confusion. We start talking about, okay, this rule is going to affect at this time and affects these people. And then we say, oh, hold up, there's a court case, so they're not going to affect at this time. And we can't tell you when they're going into effect. And that's confusing. That's confusing for people steeped in health policy. That's confusing for anyone who's just trying to look for a health plan for themselves or their family. So next slide. So we in addition to these sort of sea shifts in marketplace and Medicaid changes, there's also a sort of philosophical and policy embrace of deregulation. And what we've seen in sort of concrete actions is an embrace and a sort of policy shift to make plans that are not subject to many of the ACA benefits and consumer protection rules more easily available. And that's really the bend behind that is to make more choices available to more people. And so, not necessarily to specifically market a short-term plan to someone with complex health needs, but to market short-term plans and to market all different types of plans with different sort of benefits levels and different premium levels. What I would say about this, I think we'll continue to see it. It's definitely a priority that the administration has been pretty vocal about. I think that the concern here for anyone looking for coverage for someone or themselves with a complex and chronic condition is that even if these aren't marketed to that population, nonetheless, people could be attracted by low premiums and find that they're in a plan that just does not work for them because of their healthcare needs. So next slide. So I'll end here and really, setting up our speakers to just say, this is not just sort of an academic conversation about laws and regulations. These laws and regulations and the way in which they're implemented will have a significant impact on consumers of healthcare in this country. We have estimates from the Congressional Budget Office and other data analytics shops that federal reconciliation alone will prompt a loss of coverage across Medicaid and Marketplace plans of 10 million people over 10 years. When we add in the non-renewal or extension of the enhanced premium tax credits, that number ticks up even more. And this is in every state. So, I think in the short term, and what I'm really interested to hear from our speakers as well, is that we're entering in a really fraught and confusing open enrollment period, with consumers already starting to get notices about premium hikes right now. But Congress still debating. Late in the game actions could really change that landscape for folks. So, trusted source of information will really be more important this year than ever. So that's kind of what we are starting up against or staring up against as we look forward to open enrollment starting very, very soon on November 1st. So with that sort of rapid fire journey through some of the federal laws and regulations and other policies that have been implemented and passed in the past several months. Now we want to really focus on what does this mean for people with insulin requiring diabetes, and really hear from Laura and Dr. Rodriguez about what this looks like, what this will look like sort of on the ground. So with that, I'm going to start with you, Laura. And given that very high level overview of federal coverage changes, I'm wondering if you could give us the sort of ADA lens, and sort of what you see from your vantage point as the impact on people living with diabetes.
Sure. Thanks, Amy. Introduction was fantastic. And, obviously ADA has been looking at HR1 and the Medicaid changes and eligibility changes and generally, how to protect benefits for people who need them most. And again, all the conversations around those provisions, ADA has been focused on. We're following really closely the potential implementation of that as it relates to the accommodations for work requirements, as that was not as specifically defined in detail as part of the law. So there are a number of issues that the administration will have to act on, that we ADA will be engaging on very closely to ensure that people with diabetes have access to the care that they really need. For example, you also mentioned the enhanced premium tax credits are set to expire. We're working to advance the extension of those. As you said, there isn't anything finalized yet, but I did hear, I don't know if this is late breaking news, but I do believe a bill was just recently introduced in the House with bipartisan support that does include a 1-year extension for the enhanced premium tax credits. Not exactly sure of the timeline and how quickly that's moving, but I believe there is something out there now, which is a great start. But obviously the ultimate goal is, a permanent solution to address cost and coverage for people. But we'll be doing everything we can to at least get that 1-year extension passed. And we're working hard with other patient groups to ensure that this relief really continues. But of course, it's a little too soon to know when and how that, what that looks like. And as you mentioned before, will it be before open enrollment? And we're just not totally sure yet on that.
Thank you for that, Laura. And I think it really speaks to how fast moving everything is that we've got on the webinar updates from happenings on the Hill. So it is a dynamic space, everybody.
Truly.
If we hear any other updates during the webinar, we'll add them in live.
Truly.
Well, thank you for that. So then from your perspective, Dr. Rodriguez, as someone who's seeing patients on a daily basis, we sort of want to hear your perspective on the real world implications of these cuts. What do they mean for your patients, for people with insulin requiring diabetes? And how do you think it will impact clinical care and how you provide care?
Yeah, I mean, the short answer is, it doesn't paint a pretty picture. If you think of individuals that require insulin, it's the insulin that they require, it's the supplies to monitor their blood glucose, the supplies to administer their insulin, and those items are expensive. And just, as I kind of fold this into just the overall challenges that are faced by individuals that have insulin requiring diabetes, just day to day monitoring control of their blood sugar is a challenge. And then if you layer on top of that, them now having to navigate even a more challenging environment with regards to getting the supplies that they need, access to the care that they require. I'm a pediatric endocrinologist, and I work with families, children, young adults, and at our center we actually have adult providers as well. So we kind of see the entire spectrum, and it's getting increasingly challenging for individuals to get coverage for their clinical appointments and for their supplies. And unfortunately, when that happens, for individuals that have a chronic disease, I mean, we're all about prevention, right? We're all about optimizing blood glucose control so that they don't suffer both acute and chronic complications of the disease. And so if we don't address that question, not only does it create challenges, bad outcomes for the individual patients, but then, essentially those individuals are going to be forced to access emergency care. And we know that's even more expensive and burdensome for the families, results in poorer glucose control and outcomes, and quite honestly, as a nation, ends up being more expensive. So I think, I think those of us on the clinical side, quite honestly, I think many providers don't entirely appreciate the consequences of the legislation. I think we're going to be seeing that more and more. Just a few weeks ago, I had our mental health therapist approach me, really got an inkling as to what this is likely going to mean in terms of challenges for patients and their families. And again, I think individuals don't quite know on the clinical side what this is going to entail, but I think by all predictions, it's not going to be good. It's not going to be good, and it's going to create challenges and poor outcomes, quite honestly.
So thank you for sort of that very comprehensive picture. And I want to actually build off of something that you said in terms of disruptions in care leading to possible emergency room use and overall worse health outcomes, because I think that's, for diabetes, disruptions in care are not just inconvenient. They can really be a matter of life and death. So one thing I want to turn to you, Laura, about is to talk about churn between programs. We know that's certainly not a new concept or challenge, but do you have any concerns about continuity of diabetes care for people whose coverage might change, who might be moving from one coverage option to another, who might have gaps in coverage? And is there anything that you're thinking about to sort of help consumers navigate those shifts to ensure we don't have the gaps that Dr. Rodriguez was talking about?
Sure. We watch this very closely, frankly, every year. ADA puts out resources around open enrollment, just, again, so many different programs and plans out there that we try to, we'll stay on top. We do stay on top of that. Information is on, we have our 1-800 number you can get from diabetes.org. There'll be updates. Our social media will be continuously putting out just information around open enrollment and timeframes. So please keep an eye out for that in October. But again, in general, we do watch this closely. Again, around cost sharing, eligibility, re-enrollment. There's just so many things that affect people's ability to access coverage and care. And you touched on this, Amy, a minute ago, but one of the main predictors of good outcomes for someone with diabetes is their ability to have, continuous access to robust health insurance coverage. And We do know that 24% of people with diabetes utilize Medicaid to access their diabetes care. So, that includes insulin, healthcare provider services, diabetes devices and supplies that Henry touched on. So this is always a key priority for us. We're also focused on the state level too, because we know that as these changes, continue to happen, they're going to roll down to the states. So we'll be engaging there as well, and doing everything we can to try to ensure that people with diabetes have the information about their options for access as these changes continue to be put in place. And just one other note, we have some, I know that Christine may have put something I saw in the chat a minute ago about patient stories. ADA did put out a number of patient stories about the important role that Medicaid plays for individuals and families on our social media. And if I can be tech savvy enough to pull some of those down, I will, while we're talking, I will put that in the chat shortly.
And Amy, if I may, just to add,
Yes.
if you think of access specifically just to providers, we're not going to be talking to insulin and so forth. I'm here in Tampa. We've got quite a number of diabetes care providers in this area. And even here, in some cases, we've got families that live in Orlando that can't find, with the current status of things, can't find a provider that takes their insurance there. So they're commuting an hour and a half or more to come here. And so for those individuals in more rural and remote areas, that becomes even more restrictive. And again, as I've mentioned before, for those individuals with chronic disease, particularly with diabetes, that regular follow-up, that adjustment of therapy is critically important. And so if they can't get to their provider, if in even greater restrictions potentially in telemedicine and so forth, that makes it ever more challenging for that individual to stay healthy.
So thank you for adding that part. I think that's a really important one, and one that we see a lot of geographic disparities as well. And so I want to piggyback off of this sort of theme, Dr. Rodriguez, and turn to you, because I think with provider access and with the sort of broader access concerns that we're talking about, certain communities are disproportionately impacted. And I applaud, the ADA and the diabetes community. I think you all have been real leaders in terms of addressing disparities in diabetes outcomes and access. So I'm wondering, Dr. Rodriguez, if you have any concerns about particular communities who are living with diabetes who might be disproportionately impacted by some of the coverage changes that we've been talking about.
And again, I think that's top of mind for all of us,
Mm-hmm.
particularly for those individuals that have type 2 diabetes, and that is the vast majority of Americans. Those individuals typically fall into historically individuals that have been disproportionately affected from an economic standpoint. So they're the individuals that are really most critically in need of having coverage through social safety nets and so forth. And we're seeing, unfortunately, as part of this legislation, that that's disappearing. So I think it really is the most vulnerable individuals and families that are being disproportionately affected by these changes. And so, yeah, we're very much concerned.
Thank you for that. I think, but before we get to our Q&A, and a reminder to folks, now's your time. Get your questions in, and we'll spend some time answering them. I'm going to ask each of you a sort of like, okay, what do we do sort of question, given that we're anticipating a lot of challenges coming down the road. So I'll start with you on this one, Laura. Are there actions that from your vantage point, ADA or others there out there in the states are asking federal or state policymakers to take to sort of minimize the harm and coverage disruption for individuals moving forward?
Yeah, for a lot of these of the legislative changes that were passed into law earlier, or this summer rather, many of those provisions, go into effect at the end of next year. So we haven't quite seen anything specific come out from the administration around any sort of guidance. So, we're kind of waiting like everybody else on those changes. That said, ADA is looking at getting some additional data on those impacts, of these changes. And as we pull that together, we will be releasing that information. So, one thing I do want to mention that there are potential new resources that will be available for this Rural Health Transformation Program that was released by CMS. I don't even know if it was a month ago, a few weeks ago. So we are starting to have some conversations with some states around how they may want to include addressing chronic diseases like diabetes as part of those efforts. And I know a lot of states are just starting to look at how to apply for those. So there may be some opportunities with that, and we're trying to be creative about how we ensure that we can keep as many people covered as possible. So that's one thing I can't see if that is in the chat yet, but I can add that. That would be helpful.
Absolutely. Thank you.
Well, yeah.
Okay, so I mean it sounds like we'll keep an eye on as things roll on too. And I do appreciate your point that data drives action, including data from people who are directly impacted. So Dr. Rodriguez, I'll turn to you now. And certainly feel free to comment on federal and state policies, but also from your perspective as someone who I imagine is sort of the direct recipient of questions from patients, from families who are navigating all of these changes. What's your best advice right now as folks are trying to figure out how to navigate coverage for themselves, for their family members, and keep getting the care that they need?
Well, I think, patients and families with diabetes are, I think, accustomed to really managing their disease. They're in the driver's seat for most of it. And quite honestly, as diabetes care providers, we're there to assist them, but they're in the trenches day in and day out. And so the challenge with this is, even if you speak to those of us in healthcare, trying to navigate this for ourselves and our families is challenging enough. But for those that, again, we talked about disadvantaged individuals. At our center, we've got the luxury of having a clinical social worker who is there as a resource to families and individuals to help them manage their disease. Unfortunately, there are a lot of folks out there that don't have that luxury. And so, I think, as hopefully most people are aware, as a result of the changes that have occurred recently, there are fewer navigators that are being supported out there. So, fewer individuals for patients and their families to rely on. But I think it really is critical that they become informed with regards to what their current coverage is, what these changes are, because, as you and Laura have both highlighted, this legislation has immediate effects for some individuals, but it rolls out. And so that impact, that ripple effect is gonna cover a larger and larger number of individuals. And so I think it's critically important for folks to assess their own situation, to reach out to the resources that they have available to them, so that they can begin to plan forward. I think there are a number of resources that I rely on my clinical social worker. There are different plans. Certainly, there are worst case scenario patient assistance programs through some of the pharma companies. So there are resources. They're diminishing in number, but what we don't want folks to be in a situation is, and unfortunately happens all too often, where folks don't have access, for instance, to their insulin. They begin to ration their insulin. They cut back. And their glucose control deteriorates, and in some cases, unfortunately, they end up in life-threatening situations. So the better that we can assist patients in that process, recognizing that the resources that are available are diminishing, but at least to be able to help them plan ahead, I think that's a critical first step.
Thank you for that. I sort of like pulling out two main pieces that I think are important to lift up from what you just said. I mean, one is that that we could see reliance on a sort of fragmented patchwork of sort of the programs to fill in holes. And then two, and I think this is important because it really speaks to the important work that you do, that the staff in your office do, but providers and folks working in providers' offices are going to be the first line of questions and trying to troubleshoot and fill in gaps. And I think that's been the case, but certainly could be more pronounced in the coming months and years. I think this is a great kickoff to our conversation. We're now going to open up this discussion to all of you out there on the webinar, and we've got questions incoming fast and furiously. So please keep on asking them. And I'm going to start with a sort of a clarification, and then I'm going to turn my first question to you, Laura. So get excited and get ready. But the first one is a question about open enrollment for this coming plan year. So the open enrollment that starts in 2025 but pertains to the 2026 plan year. There was a question about when is that open enrollment, and is that the open enrollment that's affected by the marketplace integrity rule? This is one thing that I could see why there's confusion, because the original rule proposed that the shortened open enrollment period go into effect this year, meaning that we would see a 45-day open enrollment period with this open enrollment. That's not what happened, though, because the marketplace integrity rule was delayed. So the open enrollment period is the same this year as it has been for several years. So it will start November 1st. It will end at the end of January, which is good. There's lots of changes. So this will give people, consumers, assisters, providers, more time to sort of figure out what's going on. And particularly if we've got a late in the game decision about the enhanced premium tax credits, it will matter that we have this open enrollment period. The following year, so the open enrollment period that will start November 1st, 2026 for the 2027 plan year will be truncated. So important distinction, but this year it is the same as it was last year. So thank you for that question. All right, I'm going to turn this one over to you, Laura. If the midterms, so this is a political question, or projecting out what will happen if the midterms result in a change of control of either the House and or the Senate, is it possible for any of the federal reconciliation law to be repealed?
Well, great question. You're asking the policy person a political question. I mean, I guess that, yeah, I mean, it's like any law, right? I mean, I guess it would have to imagine, you'd have to imagine how large, a shift could be, right? And like, how many people is this going to be, like some major wave of change. So, I think it really is hard to plan for that. But I guess, yeah, I mean, any law can be repealed. Again, I think the numbers, I don't know if anyone else wants to jump in on the Zoom right now, but I think it's just a matter of numbers. How much of a majority do the Democrats have over the Republicans? So I think it's a little bit about that as well. It's a little challenging for me to answer otherwise, but other people have political acumen that might be a little stronger.
You did a great job with that, Laura. I think that is a hard question. I think we are in uncharted territory when it comes to predicting out politics. The only thing I will add is that the House and Senate makeup could change, but the presidency is for 4 years, and so that is just a factor in terms of both what the administration does, but then veto power over what any Congress does. So that's just something probably a mitigating factor, even if we do see a sea change in terms of House and Senate midterms. So thank you for that. I am going to go back and just answer. There were a few questions in the Q&A that, again, were more clarification, but just to make sure we all have the same baseline, because I think I went through this fairly quickly. And that is sort of the enhanced premium tax credits. What are they? How are they different than regular premium tax credits? So I just like a quick history. So the premium tax credits, a huge part of the Affordable Care Act. They are the federal subsidy that is available based on income for people who get marketplace coverage through healthcare.gov, through state-based marketplaces. and they help lower people's premiums. So that has been part and parcel of the Affordable Care Act since day one. During COVID, in many ways, in response to the crisis that we as a country were facing during COVID, Congress enacted a law that made those subsidies, those premium tax credits, more generous. So basically said, we are in a crisis. We want to make sure people can afford healthcare during a public health crisis, and we are going to bump up the value of those premium tax credits, which made marketplace coverage more affordable for more people. And those have been in place since 2021, as I said, so for a minute now. And many people have really credited those premium tax credits in combination with other policies, but those enhanced premium tax credits with driving the record enrollment we've had for the past several years in marketplace coverage as being a key factor in driving that. So they were never permanent. They always had an expiration date. They've been extended a few times, and now we are at a cliff. They are set to expire at the end of this year, meaning for 2026 plan year coverage, they wouldn't be there anymore. And that would mean that you'd still have the base level premium tax credits. It's not like premium tax credits are going to go away writ large, but it does mean you lose that extra boost. If we haven't put it in the chat already, we can do this. There's great calculators out there, including one by the folks at KFF, where you can see if your patient is on premium tax credits, you can plug in your information and get an estimate of how your premiums will be impacted if these enhanced premium tax credits expire at the end of the year. So as I said too, we are still waiting to see if Congress will address this. They haven't yet. So as of, again, right this second, those enhanced premium tax credits are set to expire at the end of this year, which will have an impact on premiums for 2026. All right. I'm going to jot down to our next question here. I'm going to turn this to you, Dr. Rodriguez, because I think we touched on this, but I feel as though you're going to have more to say on this. You talked about provider access and that being a piece of the puzzle, and certainly, provider networks writ large and provider access as well could be impacted by these policy changes. So wondering if you can speak to access in rural areas in particular, and whether telemedicine is still an option to help sort of mitigate some of those provider access problems in those rural areas.
Well, I think, because of the pandemic and ACA and so forth, there was an expansion of telemedicine because it was permitted. And I think the concern is that amongst the changes that are likely to happen is that restriction on telemedicine. So, for the patient that's in a rural, remote area that perhaps in the past was able to access via telemedicine a provider that was covered by their plan, so not only are we limiting their access to somebody that's local, we're now limiting their remote access to somebody that's a distance away. It creates challenges with regards to now their access to can they travel that distance and the expense involved with that. So, we've had this discussion, I think hopefully what results from our webinar today and ongoing discussions is that people inform themselves to the extent that they have politically and otherwise, can contribute to a changing of the guard, so to speak, with regards to the impact on these things. It doesn't paint a very pretty picture. My fear is that people are going to leave this webinar today and feel very discouraged, and that certainly is not my or any of our intents. Hopefully it's really a call to arms with regards to making sure that people are supporting in any way that they can individuals around them that are affected, but also, coming up with a strategy. And I think, as I'm looking through the chat here, I think there are a lot of great questions. Unfortunately, I don't know that we have answers for all of them.
Thank you, Dr. Rodriguez, and I do appreciate the yes, we're talking about hard things, but hopefully we're also lifting up what are we to do about it? What are the ways to help people in this fraught time? So that was actually a great segue to the question I wanted to ask you, Laura. And this is from someone who's saying that they know, looking at their own situation that they're going to lose coverage or that coverage will increase by just an astronomical amount. This person is saying that they're willing and able to call their senators and sort of have that conversation. But are there other groups who are sort of partnering with people and patient advocates on the ground in terms of the state and the federal conversations about these changes and policies that could help them?
Yeah, I mean, patient groups across, it is not just the diabetes patient groups. Obviously, um, diabetes impacts such a large swath of the population that we do work with, you know, uh, plenty of other chronic disease organizations. So I would say, even if you're just getting on Google and looking for some of the groups that you know uh, you might be hearing about, I would say most people are engaging. If you are, if an organization you are working with or know of touches a chronic illness, I think that's, a great place. But of course, we have local chapters of ADA across the country. Um, I think there's a lot of people out there doing this work. And I can see about updating specifics. Um,
And
I can get a
while
more,
you're doing that, Laura, I think,
robust list,
yeah, I think,
and
the folks that Laura's referring to are folks that are already engaged, right? And yeah, I mean, obviously biased, but the American Diabetes Association, Breakthrough T1D, there are a large number of social media platforms specifically in support of individuals with diabetes. My fear is all the folks that aren't engaged, right? That, I'm thinking of those that are most vulnerable. They don't have time necessarily to go online. They're working multiple jobs. It's those of us that are engaged, I think, really trying to do everything we can to support those that perhaps aren't, and to the extent possible, getting those folks engaged and informed, providing that information to them. Because I think otherwise, my fear is that there are quite a number of individuals that at this point are in the dark about all of the consequences that are going to occur as a result of the changes in legislation.
yeah, and as Henry shared, just start somewhere, kind of. If you know one person that you think might just not be engaged on this or aware, ask the question. Tell them I mean, you can start by talking to your pharmacist. You can start by talking to just any trusted source that might be out there, whether you have a consistent provider or not. I think just one person. Also, I had mentioned like the 1-800-diabetes number, start there, and we can help connect people to different resources as well. So that's probably as simple as it can get, but any place is a start.
And there's a comment in the chat as well. I mean, there are local resources as well, right? It may be through your community hospital or, community clinic, that kind of thing. It's important to explore all of those options.
That's great. Thank you both for those very, very practical suggestions of where to go for information. I think that's super important in times of stress and complexity. So I'm going to turn this question to you, Dr. Rodriguez, and this one warms my cheer heart because it's very it's insurance specific. You talked a bit about some of the insurance questions that you get that the other the folks that work in your clinic get, and so I'm wondering if you have sort of concrete advice for folks who are comparing plans where there's high deductibles or co-insurance that obviously, those types of plan designs can have a really big impact on what people pay, especially for higher cost diabetes medications and supplies. But it's often not clear from just seeing a deductible amount or seeing a co-insurance amount what exactly that cost is. Do you have any tips or tricks for how to compare those plans and really understand, what is the bottom line of what folks will be paying?
I mean, quite honestly, the short is no. I mean, I think there are some resources available online. Um, I think as you outlined in your introduction, part of the challenge here is that there's an effort underfoot to deregulate. And so I think, folks approach plans looking at the deductible without looking at potentially the coverage. So I think sitting down, looking at, what medications you're on, which providers you see, and again, doing the challenging work, which is kind of looking through the fine print on, and it's difficult to do that, even for those in the healthcare community, to try to determine what is covered, what is not covered, and then to make things even more challenging. Unfortunately, what we see is that even with staying with the same plan, formularies change, coverage changes, and so even if you're fortunate enough to have coverage through your employer, for instance, they're going to perhaps change plans, and even within the same plans, therefore. And so, it used to be, I think, years ago, maybe less common, but we see it all the time. A patient is on one brand of insulin and it's been working well for them. Well, now they have to switch to another one. And it doesn't just happen once. It seems to happen for some patients. Every visit I see them, we try to see them every 3 or 4 months. And it's always a change, and they're requesting a change for a prescription because not be any of their choice, it's really been their provider. So again, no, I'm sorry to disappoint you, but no tremendously wise answer to that one. I think that, plans are very, very different, and I think really diving into the details to try to explore just what the coverage is for a specific individual and the therapies and the providers that they have.
Thank you for that. You really unpacked a lot, and that was kind of a loaded question for you. So thank you for that. And we got one question where I think we've got time for 2 more questions. So I'll start with this one, which I think dovetails under what you were just saying, Dr. Rodriguez. And this one was sort of given all of the unknown. And particularly the potential for Congress to act later in the game on enhanced premium tax credits. Is there a benefit for waiting to enroll? And not being the first one to enroll on November 1st. I'm going to say I'm curious if you all, Laura and Dr. Rodriguez, have different opinions on this. I would say there probably is benefit in waiting a minute. I have worked with HIV navigators for a long, long time, and our rule of thumb was always give it a minute, like let other people test healthcare.gov. The stakes are a lot higher if you're trying to figure out, what is your provider network and coverage landscape for someone with a chronic complex condition. I think probably the same advice would apply here. You don't want to wait too long. You don't want to forget. But I think it may make sense to kind of give it a minute. There's not really a benefit other than like a sort of peace of mind to getting it done early. But I'll ask if Laura or Dr. Rodriguez has any other thoughts about that.
Yeah, I mean, I think I agree with you. You don't need to be, you know, solidifying coverage. Maybe start shopping
Yeah.
early to understand that if there aren't any changes, it would be helpful to kind of, just be prepared, and then do your due diligence. But right, you don't have to like submit for coverage November 1st, right? If you have until I think it's December 15th, we said, right? I mean, again, you don't need to be the first one there, but it never benefits to wait too, I don't know. The benefits of waiting too long make me stressed as well, too.
Exactly.
So, I think researching and kind of getting your bearings around what is being offered first is important. And then and then I'll pause. Dr. Rodriguez, you may have something since you are a physician, and maybe, talking to your physician about it, if you have a dedicated person you work with, I think that's important.
I mean, I guess my perspective is if you have the luxury of waiting, that's great. But I think we also need to acknowledge that there are individuals where, their employment status may change, or, there are a lot of variables there where, they may not have the luxury to say, you know what, I'll wait. I think if there's an opportunity for some individuals to get coverage now, and there may not be later, then I think that kind of forces their hand. So, you know, again, it's not ideal, but it kind of comes back to, which is, you know, not the most satisfying answer, but, you know, each individual kind of has to look at what their individual situation is and reach out to the resources that they have and to those that can perhaps expand the number of resources that they're aware of to really best position themselves to deal with what's next.
Thank you for that. That was a nuanced answer from all of us. So I appreciate that. We are quickly running up against the top of our hour, so I'm going to have this be the last question for you, Laura. And this one is sort of recognizing that even in this tumult, we still have you know, questions that have been on our minds in the diabetes space for a while now. So wondering if you have any insight or thing to say on CMS and CGM coverage for people with type 2 diabetes and whether that's something that might move.
Yeah, I see the question, you know, a crystal ball.
Yeah, yeah.
Absolutely no crystal ball ever with any of this stuff. But, you know, ADA standards of care, you know, do recommend now these were updated. So the last iteration are 2025 standards of care, which are updated annually. So new standards will be coming out January 2026, but January 2025, ADA did update its recommendation on who should be getting access to, or who we recommend should have access to CGM coverage. And we extended that to, or expanded that rather, to individuals who are taking any glucose lowering medication, so not solely insulin. You know, there are a lot of other medications out there, oral medications that that people are on. So want to just flag that you know, is perhaps another step in the right direction. And again, for right now, type 2s on insulin do have access to CGM under Medicare. And in many states, Medicaid as well.
Mm-hmm.
So
thank you for that crystal balling
sure.
and what to expect in another area that we should all have our eye on in the future.
Yeah.
So I'm looking at the time. I think this is likely a good time to end us. We're coming up on our hour. I want to give my heartfelt thanks to Dr. Rodriguez and Laura. This was a really fun discussion, and I think we did find some lights of hope in I think a hard time. And thanks for all of you out there for listening, for adding in your questions. Thanks as always to our funders at Helmsley Charitable Trust for making all of this possible. When you exit the webinar, you'll be asked to complete a survey. Please do. It won't take long, I promise, but we do actually use that information to help us plan future webinars. And watch this space for more to come, more webinars. So thank you again, everybody.
Thank you.
Thank you.